mainly a localized tumor, to a fissure tumor where the breast cancer was a more systemic disease where there could be hematogenous spread and micrometastasis also. And that led to the advent of adjuvant chemotherapy. CMF was the first regimen to be approved in the adjuvant setting and to show improvement in disease-free survival and overall survival. Following CMF chemotherapy, there were a lot of trials using different medications, initially anthracyclines and then taxanes also. So the conclusions we came to towards the end of our last talk, a lot of it was based on all the adjuvant trials that were done in breast cancer, and the early breast cancer trialist collaborative group that was there, which did these large meta-analysis to look at and between the trials and the EBC-TCG analysis, meta-analysis, the conclusions we could arrive at was one, yes, definitely adjuvant chemotherapy is effective in decreasing the risk of recurrence in breast cancer. Polychemotherapy is better than single agent. 4 cycles of anthracycline chemotherapy is equal to 6 cycles of CMF chemotherapy. When they replaced the methotrexate with epirubicin or adriamycin, the FAC and FEC regimens, these triple drug regimens seem to be anthracycline CMF. So 6 FAC or 6 FEC seem to be superior to CMF in overall survival. It was probably also because of the higher dose of anthracyclines that we were giving to the patients. And the magnitude of benefit that we were seeing was similar across all subgroups, regardless of the patient's age, tumor size, nodal status, hormonal receptor status, the grade of the tumor. All patients seem to be benefiting from adjuvant chemotherapy. So the relative risk reduction was the same. The absolute risk might not have been great based on the patient. When coming to the taxanes, when we added a taxane to these anthracycline regimens, definitely there was a decrease in the risk of recurrence and mortality also. And again, the magnitude of benefit was similar across all subgroups. It seemed that for taxanes, sequential was better than concurrent in terms of tolerating the treatment and in improvement of DFS and overall survival. Weekly paclitaxel appears to be the best possible way of delivering a taxane in terms of improvement in DFS and OS. 3 weeks is not far behind. And there are what we call dose dense. And the meta-analysis also showed and multiple dose dense regimen trials showing that there is an improvement higher risk patients, triple negative patients, patients with high risk, those they seem to be benefiting better. For lower risk patients, anthracyclines completely because of the risk of cardiac and hematological toxicities. And 4-TC was tested, and 4 cycles of docetaxel cyclophosphamide was better than 4 cycles of AC. However, there is no evidence today to show that TC is better than anthracycline and taxane combination, and no evidence to say that TC is better or equal to 6 cycles of FEC. So where do we use a regimen like this in today's age? We basically use it in low risk patients who are node negative, ER positive, or if there is a contraindication to an anthracycline. Just give me a break for 1 second. We also spoke about all breast cancers not being the same, that initially we looked at breast cancers based on the histological subtypes, and the most common that we see are the infiltrating ductal and lobular carcinomas. But even amongst that, suppose I have many patients with the same 3 centimeter infiltrating ductal carcinoma, which is node negative, I still see that some patients are recurring and some patients don't recur. So are there any other prognostic factors that will tell us who are the patients who have a greater risk of recurrence? And maybe those are the patients where we should be giving more treatment. And the prognostic factors that have been validated in breast cancer, one is the tumor size, as we all know, nodal involvement, metastasis, of course, the tumor morphology, tumor grade, lymphovascular invasion, the Ki67 or proliferative index, hormone receptor status, and HER2 expression. So we all know that patients who have lymphovascular invasion, higher grade tumors, higher Ki67, hormone receptor negative patients, and HER2 overexpressed patients are the ones who do poorly compared to patients who do not have any of these features. But this is still does not give us the whole story, and gene expression profiling was something that was done and found to have, if we differentiate patients based on their gene expression profile, again we see that patients who have the luminal A type of breast cancer, which is hormone receptor positive, low Ki67, is the group that does well compared to the luminal B, and then the basal like, that is the triple negative breast cancers, and the HER2 enriched. So this is again important for us to know when we seeing a patient what is the risk of recurrence and what is the role of adjuvant chemotherapy in these patients. Now, digressing a little bit, I'll just talk about neoadjuvant chemotherapy, just a few slides. Initially, we were doing neoadjuvant chemotherapy mainly in patients who had locally advanced breast cancers where immediate surgery might not have been possible, or patients where we thought that if we gave chemotherapy first, we might be able to enable breast conserving surgery. So, to enable a definitive surgery to be performed, that is the most common reason that neoadjuvant chemotherapy was used. We also asked the question, and multiple trials were done to see if giving neoadjuvant chemotherapy beforehand and getting rid of any micrometastatic disease beforehand, before doing the surgery, will lead to improvement in disease free survival and overall survival. And the big overall answer is no. Neoadjuvant chemotherapy, whether you give the chemotherapy before or after surgery, it doesn't matter. The overall survival remains the same for most patients. The second question asked was, can we, based on the neoadjuvant chemotherapy, tailor treatment based on the response to surgery? So if a patient is given neoadjuvant chemotherapy and then we do the surgery, we assess the response of the treatment on the tumor and then subsequently decide how we want to treat the patient. Is that something that neoadjuvant chemotherapy will be useful for? And that is what we will talk about a little bit in today's talk. How best do we evaluate a response to neoadjuvant chemotherapy? There are multiple things that we looked at, but what has panned out is the pathological CR, that is pathological complete response. Now, even there, the definitions of PCR vary. Are we saying pathological CR is where invasive carcinoma and carcinoma in situ both are gone? Is it where there is no cancer in the breast and no cancer in the nodes? So, what is our actual definition of PathCR? And that has been varying. So, to come to a commonality for all this, the FDA requested for a collaboration, or was commissioned by the FDA. This was called the Collaborative Trials in Neoadjuvant Breast Cancer Group, to see one, how do we define PathCR, and second is, can PathCR be a surrogate endpoint for long-term outcomes? Meaning that if in a trial patients are shown, one group is shown to have more pathological CR, can we just automatically interpret that this is, it means that there is an improvement in disease-free survival and overall survival? So is pathological CR a surrogate endpoint for disease-free survival or and overall survival? The advantage is that our trial durations become shorter and we will be able to get drugs more easily to patients. If I say that this group, if I give a particular medication, improves pathological CR, and if we can prove that pathological CR is equal to an improvement in disease-free survival and overall survival, then the trial durations automatically will come down and we will have a quicker, fast track way of giving trials to patients. So this is the Cortazar meta-analysis where they looked at 12 international neoadjuvant trials, and in that were included 3 trials which had trastuzumab also in the neoadjuvant setting, and the other trials had a quite heterogeneous population of patients, and all these trials were looking at neoadjuvant versus adjuvant chemotherapy. And long story short, what did this find? One is that Patients who achieved PAT-CR had longer event-free survival and overall survival than patients who had residual cancer. So you could be in the group that received only chemotherapy and achieved a PAT-CR. You could be in the group that received chemotherapy and trastuzumab and achieved a PAT-CR. Regardless of which group you were in, if you got a pathological complete response, you did very well and your event free survival and overall survival were much better. So it's important to remember that this is for an individual patient. Who were the patients in whom we were seeing high rates of pathological CR? When we looked at the different types of breast cancer, the patients who were HER2 receptor positive and the triple negative patients were where PAT CR seemed to be the highest. Also, in among HER2 patients, there was a greater pathological CR in patients who were the HER2 hormone receptor negative patients. So, to conclude, pathological CR improved outcomes in individual patients, both in the triple negative breast cancer and HER2 positive. But please remember, PAT-CR was not validated as a surrogate endpoint for long-term outcomes. So, at an individual level, for that patient, if Meenakshi comes to me with breast cancer and she has a pathological CR, I'm very happy for her and she will do well long term. But if there are 100 patients in a trial and we see that giving a particular drug improves pathological CR, that is not equal to an improvement in event-free survival and overall survival. So the was to use this as an accelerated approval pathway, but we should be having phase 3 trials showing event-free survival or improvement in overall survival. For example, there were many trials, and I have not included them or gone into detail, but we had improved pathological CR with bevacizumab, lapatinib, the NeoAlto trial, carboplatin, all showed much improvements with PAT-CR, but there was no improvement in the disease-free survival or overall survival. So lapatinib, the NeoAlto trial showed an increase in PAT-CR, but the Alto trial did not show any improvement when the same treatment was given in adjuvant setting. So, keeping these in mind, the role of adjuvant chemotherapy, the conclusions that we have received reached us broadly, and neoadjuvant chemotherapy, and how we can use neoadjuvant chemotherapy to tailor treatment for our patients. Now, let's go into detail for each type of a breast cancer. So, today I will be talking about triple negative breast cancer and HER2 breast cancer and seeing how we tailor our treatment based on the knowledge that we have got from the existing trials. So coming to one, that is the triple negative breast cancer. So this is about 10 to 15% of all diagnosed breast cancers. What do we mean by triple negative breast cancer? It means that these cancers do not express estrogen receptor, progesterone receptor, or HER2. So since they do not have any target for which we have a medication, they are the poorest prognostic group. More often, they are associated with genetic conditions, and we see more BRCA mutations in patients with triple negative breast cancer compared to a hormone receptor positive breast cancer. Remember again, all triple negative breast cancers are not poor prognosis. Morphology definitely matters, and it is the patients with infiltrating ductal and lobular carcinomas who have the poorest prognosis in TNBs. So, if I see an adenoid cystic patient with a triple negative, many adenoid cystic patients are ERPR HER2 negative, or a metaplastic patient with ERPR and HER2 negative, that is expected for that morphology. It doesn't mean that it is the usual scary triple negative breast cancers that we talk about, and does not mean that these patients will be getting some dose dense chemotherapy at all. So we also have to look at the morphology and understand that it is triple negative. All triple negatives are not the same. Is there anything different about patients who have triple negative breast cancer? One is the relapse pattern. So they have a very short disease-free interval and they have more visceral metastasis. Like for hormone receptor patients, we see more bone metastasis. In triple negative patients, we see more visceral metastasis. And the recurrence also is very fast. So we usually do not see recurrences which are late in triple negative breast cancer. and CNS metastasis is also common. Now, so as you can see in this graph, most of the recurrences occur within 5 years, after which we see very few recurrences compared to your hormone receptor positive group, where there's a constant group of patients who will keep recurring every year. Uh, so, what we usually tell our breast cancer patients is that the first 3 years are when there is the maximum recurrence, and if they don't recur within 5 years, it's unlikely that they will have a recurrence, distant recurrence. This is more important for patients with metastatic triple negative, and if we ever talk about it, we'll go into details about this. Again, looking at the molecular classification of triple negative, this is again to prove that all triple negatives are not the same. And this hopefully with time will help us in tailoring treatment and finding targets on for treatment of TNBC. So, what is the data we have specifically for triple negative chemotherapy? So, questions we are asking is, when do we start treatment? Which regimen is the best for triple negative breast cancer, or do we just go with the conclusions that we arrived at earlier? What about very small lesions, the T1As and the T1Bs? Previously, somebody had asked me the role of platinum agents in triple negative breast cancer in the adjuvant setting, and is there any benefit of a neoadjuvant approach? So, we will look at each one of this. One is, when do we start triple negative patients? When do we start chemotherapy? And this is where they have looked at thousands of patients, 24,000 patients, and time to chemotherapy. They analyzed the time to chemotherapy and saw the correlated it with the overall survival and breast cancer specific survival. And if you look at the graph here, you can see that if the treatment was started in less than 30 days, there was definitely a better disease-free survival compared to where there was a delay in starting adjuvant chemotherapy. So when a patient comes with triple negative breast cancer, we prefer to start the treatment earlier rather than later. Second question, what type of regimen do we give? And like we had discussed before, in all patients, regardless of their hormone receptor status, there is a benefit of giving anthracycline and taxane. But the maximum benefit that we see is in patients who are HER2 negative and ER negative. So that is the first graph here that we are seeing. So in these patients, we see a really wide difference between the two curves, the patients who are getting paclitaxel versus the patients who are not getting paclitaxel. So patients who are triple negative, similarly patients who are HER2 positive, hormone receptor negative, are the patients who seem to be benefiting maximum from a taxane based treatment. This is another trial. We have discussed it the last time, the Sparano trial, where again, when they looked at dose dense regimens and which is the best way to give taxanes, is it weekly, 3 weekly, is it docetaxel, paclitaxel. Again, in this trial also we saw that triple negative patients are the ones who have the best improvement in overall survival and DFS when weekly paclitaxel is given. This is another trial coming to the same conclusions. EC for every 2 weeks, 4, that is a dose dense regimen, followed by weekly paclitaxel for 12 weeks, and patients with TNBC were the ones who did the best. So earlier, the better dose dense regimen with weekly paclitaxel is the treatment of choice. Next is the small tumors. So, we are so scared of triple negative breast cancer. Should we really be so worried about them? What about a patient if who comes with a zero point 0.3 centimeter tumor or a zero point 0.5 centimeter tumor? And so this is a study, again, a large database where they looked at 13,000 patients with breast cancer. And here, when they looked at the triple negative group and patients with the tumor smaller size, T1A, there does not seem to be a benefit for chemotherapy for these patients. But T1B patients, definitely chemotherapy seems to be making a benefit. Improvement we are seeing. T1C, of course, we are seeing an improvement. So look at the numbers and the difference in the survival. So definitely for T1B and T1C, Even if they are small, node negative, there seems to be an improvement in survival with adjuvant chemotherapy. T1A, not so much in this. So for patients who are T1B, we definitely think of giving chemotherapy. We usually have a discussion with the patient on whether to give a TC chemotherapy or an AC followed by taxane chemotherapy. For much smaller tumors, like if you have a 2 millimeter tumor or a 4 millimeter tumor, then it's really case by case basis. And we will discuss towards the end what we mean by a case by case basis. So, but everybody else, they will be getting chemotherapy with anthracyclines and vaccines. Now, we had discussed before that in neoadjuvant chemotherapy, patients who have a pathological CR are the ones who do better. And coming to the role of carboplatin. So, is there any role, any benefit from adding carboplatin for patients with triple negative breast cancer? So, it has been studied in multiple trials, and I will talk about the 3 or 4 biggest trials that have been done till now. One is the JAPAR 6 trial. Here, they looked at patients with stage 2 and stage 3 triple negative breast cancer. It is not a regimen that we use commonly in breast cancer nowadays. So this was a combination of pegylated liposomal doxo with paclitaxel and bevacizumab, and they added carboplatin in one group. What we have done that there is an improvement in pathological CR. Definitely, it increased when we added carboplatin. Path CR increased from 37 to 53%. Similarly, another trial, CALJB 40603, in this trial too, again, they looked at one, the role of bevacizumab and the role of carboplatin. And is there any benefit in adding any of these drugs? What did we find? Again, when we add carboplatin, there is an improvement in pathological CR, both in the breast and axilla. However, translate this does not translate into an improvement in disease-free survival or an overall survival. The endpoint for these studies was actually only path CR. In the JAPAR 6 study, there was an improvement in event-free survival, but they were not meant to look at that. That was not a primary endpoint of that study. This is another study called the brightness study, where again they're looking at the standard chemotherapy. Is there any role of adding carboplatin? Is there any role of an additional PARP inhibitor to carboplatin? And similar results. There was an improvement in pathological CR when you added carboplatin. PARP inhibitor did not do much in addition to that. But beyond this, there was not much gain in the trial. So what can we conclude from this for carboplatin or any platinum agent in triple negative breast cancer? Definitely it increases pathological CR by 20%, but the PFS and overall survival benefits are uncertain. We have to remember that when we add carboplatin, it is not an easy addition. Even when we give it weekly or we give it 3 weekly, there is an added hematological and neurological toxicity. So we do see more neuropathies, we do see more thrombocytopenias. So you have to choose your patient correctly if you're even planning to give carboplatin in the TNBC setting, because the benefit is from your dose intensity. So by giving treatment on time, you're starting treatment within 3 weeks and you have to give the treatment on time. So if you think that adding another agent is going to add to the toxicity and it will lead to a higher level of discontinuation, then it is something that would not be recommended for that particular patient. Now, lot of talk also about TNBC patients. We are seeing more BRCA mutation, and platinums maybe they work better in BRCA mutation patients. However, that has not panned out, and both the can we mute some of the yeah, thanks. So both in the brightness trial and in the JAPAR 6 trial, actually the patients who had the BRCA mutation, the wild type for the group seem to have better PCRs and better disease-free survival. So if you see in the brightness trial, the magnitude of PATH-CR improvement with carboplatin here is actually 30%, here it's only 9%. And in the Breast-2 trial, when we look at disease-free survival, there is an improvement by 11%. So the number, if you see, 11% improvement in the wild type, whereas in the BRCA carriers, it is only 4%. So maybe the BRCA carriers are a better group to begin with. They have better CRs, they are more responsive to platinum. The magnitude of difference between the two is not much. So is that a special group where we should be using carboplatin? Again, we have no answer to that. All this data, what can we say? I mean, how do we use this PAT-CR? So this was a very nice study done where they gave neoadjuvant chemotherapy followed by surgery. And after the surgery, we looked at the response. So is this a patient who has a PAT-CR or does not have a PAT-CR? And randomized those patients who did not have a PAT-CR. So this is a higher group patients, right? Higher risk patients, and randomized them to doing nothing versus giving capecitabine. And there was an improvement in disease-free survival and overall survival, 89 to 94%. So the 5-year overall survival is 83 to 89. So this is a a proof that we can use pathological CR to tailor therapy after. So maybe we can use the results of this trial to give capecitabine for patients who do not have a bad CR. But it did not catch up very well with many medical oncologists. So even though the numbers that you see are quite good, right? It is these numbers that made taxane the mainstay of chemotherapy. So how come capecitabine has not caught on so much? One is that you are giving it for a very long duration. Second is that this dose of capecitabine is not an easy dose to give. Even though we say capecitabine is a hormone, is a oral therapy, and it should be, we tell our patients it's a tablet, you go home and you take it. But anybody who's given capecitabine, especially at this dose, will know that it's not a fun treatment to take. Hand-foot syndrome, diarrhea, fatigue, that comes with it. It's not an easy regimen, especially for patients who've already seen anthracyclines and taxanes. So definitely a point of discussion with our patients, but it has not caught on so much. So chemotherapy, coming to our initial questions, when to start? Within 30 days of surgery. Which regimen? Where we usually go with dose-dense anthracycline and taxane for T1A and 1B lesions. Roll of dose dense, and or do we go with a lower risk regimen like TC is a conversation that we have with our patients and the benefit that they are going to get with a higher risk. T1A lesions, most likely, most patients we usually don't give chemotherapy. Carboplatin improves PAT-CR, but there is no DFS and overall survival benefit. So maybe in patients where we want rapid locoregional control, so patients who have a large breast mass where I'm worried about how will I control that mass and also about metastatic disease, those are the patients maybe where I can give carboplatin. Or if it's a younger patients where the risk is more. Then benefits of neoadjuvant approach and tailoring treatment with capecitabine. Createx was the study we looked at. The other study that was released in ASCO this year is where again patients who were stage 1B to stage 3 triple negative breast cancers and had completed the standard treatment of chemotherapy and surgery, they were put on a capecitabine maintenance. Now, this is a lower dose, but it's not the 2 weeks on, 1 week off schedule. So, this is 650 milligram per meter square BD and seems to be a better tolerated regimen, and we are seeing improvements in disease free survival and overall survival. And this was tested both in the neoadjuvant and the adjuvant chemotherapy setting. So I think this is something we should be considering. If a patient who's already had TNBC and comes and is a high risk patient, then this is something that we can consider after finishing our anthracycline and taxane. But if the patient who had neoadjuvant chemotherapy and has not had a PAT-CR, again, this is a more doable regimen compared to the other the regimen. So definitely improvements in overall survival and DFS, and there is a numerical difference in the overall survival. Another trial that we are looking at, waiting for results, where patients who don't have a PAT-CR now are again randomized to capecitabine versus a carboplatin. and that might be a better way of using platinum. So that is about triple negative breast cancer. Coming to chemotherapy in HER2 positive breast cancers. So, as you all know, for HER2 positive breast cancers, targeted therapy is available, and trastuzumab has been around for more than 10 years now. So, the questions that we are asking are: one, is there a benefit? We know that there was an improvement in survival. That is how it was introduced in the market, was in the metastatic setting. Did that translate to an improvement in survival in the adjuvant setting? And there were multiple trials that were done, and we'll go over them a little bit. But uniformly, we can see that there was a 30 to 40% improvement in disease-free survival and overall survival. So the questions that we are asking for HER2 positive, when we know that trastuzumab works, is one, how best do we give trastuzumab? Do we give it with chemotherapy? Do we finish all chemotherapy and sequence it? What about trastuzumab in smaller tumors? Is there any role of less trastuzumab? And what about the newer agents? So we go over each one of these one by one. So, like I said, the relative risk reduction anywhere between 33 to 59%.
Excuse me. Can
Landmark.
someone mute? Can the host mute the other participants?
These are the landmark trials that have been done for adjuvant trastuzumab, and it would make sense to read at least one or two of these trials, just the beautiful way in which they were designed and the responses and the improvement in disease-free survival and overall survival. I think what is remarkable is that across the trials, the type of benefit that we are seeing remains the same, proving again and again and again that 1 year of trastuzumab definitely improves survival. Absolute improvement is in the 10 to 13% range. So the HERA trial, the NSABP trial, the trial where they looked at trastuzumab in a non-anthracycline regimen, that is your BCIRG trial. Everywhere there was an improvement in disease-free survival and an improvement in overall survival. All subgroups again, regardless of your nodal status and regardless of your hormone receptor status, everybody benefited from trastuzumab. Once again, the magnitude of benefit was the same. The relative risk reduction was the same, regardless of which group the patient came in. How best to give trastuzumab, and this is what we saw in the 9831 trial, where they looked in both ways, sequential and concurrent. And as you can see, the concurrent chemotherapy trastuzumab performed better than the sequential regimen. So there is another 5% improvement by giving it concurrently. So I think it is always better to give the trastuzumab together with the taxane chemotherapy. What about in small tumors? We have to remember, similar to the triple negative data, we also have data in the HER2 positive. Before trastuzumab, this was a poor prognostic group. That is one thing to remember. Patients with HER2 positive breast cancer do poorly compared to ER positive tumors. Today, we are not very scared about it because of the availability of trastuzumab. So, in smaller tumors also, should we be using trastuzumab in the in the adjuvant setting? And this shows that both in hormone receptor and hormone receptor negative patients, there is an improvement in recurrence and overall survival, even in patients who had small tumors. So there weren't a large number of patients with T1A, 1B, but definitely there seems to be a benefit of giving trastuzumab. So for a long time, we were wondering what to marry the trastuzumab with, which kind of chemotherapy regimen. If I have a patient with a 0.8 centimeter tumor or a 1.2 centimeter, 1.3 centimeter small tumor, hormone receptor positive, do I have to put the patient through AC and then a taxane and then trastuzumab for 1 year? So luckily for us, the answer came in the form of the APT trial, another landmark trial. This was a prospective, non-randomized. It is a single-arm trial where they looked at patients with low-risk disease. So these are patients who are node negative and tumor size less than 3 centimeters. And in these patients, The regimen given was weekly paclitaxel with trastuzumab, followed by completing 1 year of trastuzumab. So this is an anthracycline-free regimen with weekly paclitaxel, with the primary endpoint being disease-free survival at 5 years. The updated results again show that the recurrence-free survival at 7 years also it is still holding. There is an improvement in the recurrence-free survival, and look at the very good numbers. 97% of these patients are still alive without disease at the end of 7 years. So definitely trastuzumab has been a wonder drug, a miracle drug for these patients, and we can avoid chemotherapy, anthracycline chemotherapy, and do just paclitaxel weekly along with trastuzumab in patients who have lower risk HER2 positive tumors. Is there any role in the HER2 low disease? And the answer is no. Cardiac safety, we all worry about it, but it is very unusual to have a patient stop treatment because of a cardiac issue. So now we follow the ejection fraction closely. We look at it every 3 months, and we have strict guidelines on how to handle trastuzumab based on the ejection fraction changes. So I think we've got better at detecting and managing EF. And cardiac problems. Coming to where can we go now? So we know that trastuzumab is definitely beneficial for these patients. What do we do next? And there the new words that we are hearing nowadays, one is escalation, the other one is de-escalation. So can we decrease the period of trastuzumab? It was tested for 1 year. They escalated it actually in the HERA trial. There was one arm which looked at trastuzumab for 2 years and did not show any further improvement after the 1 year. Now, can we bring it down to 6 months or 9 weeks? And that is more important for our settings where financially also it is difficult for patients to afford a year of trastuzumab. So there were multiple trials done. These are the de-escalation trials where there were some trials which looked at trastuzumab for 6 months. That's the first three trials. And then these are the trials where they looked at trastuzumab only for 9 weeks. What did we learn? 4 out of the 5 trials, unfortunately, did not show non-inferiority. So again, it shows that trastuzumab for 1 year remains the standard. Only the Persephone trial, which was a phase 3 trial again, where they looked at 1 year versus 6 months. This was the only trial where there was an improvement in disease-free. I mean, that there was a non-inferiority was proven, and there was no difference in the disease-free survival. Maybe these were patients who are at much lower risk of recurrence to begin with. So definitely de-escalating is something that we can think about, but we have to be very careful with the patients that we choose for de-escalation. We cannot say that it is the standard of care right now. The next question was, so that is about the de-escalation trial. We also looked at one more trial called the ATTEMPT trial, which was just presented in ASCO this year, where instead of the APT regimen of weekly paclitaxel plus trastuzumab, we could substitute that with TDM1, which is a non-chemotherapy regimen, but it's not a regimen without side effects. But when they compared both the regimens, they did not find any difference. So even there, we have not shifted to TDM1 for lower risk patients. Weekly paclitaxel with trastuzumab remains the treatment of choice. The other de-escalation was a non-anthracycline regimen of TCH, which was in the BCIRG, and again, TCH was shown to be equivalent to an anthracycline-based chemotherapy. So there is some, subgroup analysis, smaller data sets coming, which tell us that anthracycline-based chemotherapy is slightly better than the TCH regimen. So generally, as medical oncologists, what we do is if it is a patient who has any cardiac risk factors or diabetes, hypertension, then we go, or older patient, we go with the TCH regimen. For the rest, we are using anthracyclines. But overall, I think they're fairly equivalent regimens. Now, what can we do to make things escalate? So we learned about de-escalation and am I going backwards? Yes. escalation. So do we have to add other medicines? By adding other medications, and the new kids on the block here are pertuzumab, neratinib, Kadcyla. By adding other targeted therapies which are directed at HER2, is there going to be any difference? So please remember what I spoke about in the neoadjuvant setting. So when these regimens were tested, when pertuzumab was tested in the neoadjuvant setting, there was definitely an improvement in the pathological CR. But the question is, did it translate into patients living longer, patients living without disease? And that was the confirmatory trial, which was called the affinity trial. And this was presented 2 years ago, 3 years ago, and unfortunately it did not show as much benefit in the that we wanted to see. So the number was quite disappointing, even though the p value was 0.045. And it was clinically, there still today it remains a discussion on what it means to have a 4-year invasive disease free survival and absolute benefit of 1.7%. Is that really meaningful to the patient, to the doctor, to the bank? So this is something that we have to think about. So overall, when we look at the entire group, that is the improvement that we are seeing in invasive disease-free survival. Even though there was an improvement in PAT-CR by 20%, this is what we found in the adjuvant. So lesson 1 is look at the PAT-CR with caution, and lesson 2, it might not always translate, and affinity is one more trial that was disappointing. However, when we looked at the subset analysis, the absolute difference increased in patients who were node positive and who were hormone receptor negative. So as we know, among HER2 positive patients, these are the higher risk patients, right? So, and these patients were the ones where we saw a further improvement. Now, again, this is an improvement in invasive disease-free survival, not an improvement in overall survival. But this is the number that we have to talk about: 3% improvement in absolute invasive disease-free survival. So, is that worth it for the patient or not? Is debatable. So role of pertuzumab, definitely not in all patients. To date, there is no improvement in overall survival. To be discussed with the patient and with ourselves on whether there is any role in high risk patients, those who are node positive, hormone receptor negative. The good thing is that there is not much additional toxicity. If the patient doesn't have the diarrhea from the pertuzumab, otherwise it is a very well tolerated drug. And of course, financial burden, both in our settings, and thanks to pertuzumab, they're discussing costs in America and Europe also. Next is a drug called neratinib, which is not available in India. It is a pan-HER inhibitor, which decreases the downstream signaling. And this was a drug that was used in patients who completed 1 year of trastuzumab, and then they were randomized to a year of neratinib or placebo. And what did we find? We found that again, invasive disease-free survival, it was better in patients who were hormone receptor positive, did not have much of a benefit in hormone receptor negative patients. So ulta. So in patients who have hormone receptor positive disease, if we think they are high risk, you can consider giving patients extra 1 year of neratinib. But neratinib brings within itself the gift of diarrhea, and almost 80% of the patients have diarrhea. Lot of it is grade 3, grade 4. There is now data coming that you can manage it well with Imodium, and there are protocols on how to manage the diarrhea so that it's not so much of an issue. But whether patients would like to go through this 1 year of neratinib, same like the Createx capecitabine study. So it's a difficult drug to give, and the benefit of an improvement in disease-free survival of 4%, is that worth it, is what we have to talk about. Especially when we have new drugs like pertuzumab. Most of the patients in the neratinib trial did not get pertuzumab. So in the setting of pertuzumab, would I rather spend that money and finish it off in 1 year with pertuzumab rather than go for a neratinib later on, another year of treatment? These are things that we have to think about. So coming to the last trial that I wanted to talk about, and that is the role of TDM1. So as you know, this is an antibody drug conjugate. TDM1 is an antibody drug conjugate. And what they did was, and again in an interesting way, similar to the CREATEC study, tailoring treatment after surgery using the pathological CR. So patients who have HER2 positive early breast cancer, neoadjuvant chemotherapy and Herceptin was given to these patients. After that, surgery was done, and patients who had PATH CR were not treated in this trial. Those who did not have a pathological CR, these patients were randomized to trastuzumab versus TDM1. The primary endpoint was invasive disease-free survival. And this was published in New England Journal last year, and there was an improvement in invasive disease-free survival. Now these numbers are happier numbers here. So 77% to 88% is a 3-year improvement in invasive disease-free survival, a 6% improvement in freedom from distant recurrence, and overall survival also there was a numerical difference in the number of deaths. So this seems to be making little more sense, and I think much more exciting, because here we are able to pick those patients who we think will benefit from a particular treatment. So in a way similar to when we do pediatric tumors, so who are the higher risk tumors, which children, and we give them the more therapy, and lower patients we want to de-escalate treatment. So the Catherine study that way is a very exciting study, because we are selecting patients based on their PAT-CR, and then we are demonstrating an improvement in disease-free survival and freedom from distant recurrence, both by using a particular drug and by making that intervention. So to conclude, for HER2 positive breast cancers, is there a benefit for HER2 directed therapy? And the answer is yes. Concurrent versus sequential, concurrent. Chemotherapy in small tumors, yes. But APT regimen is now the standard. Um, and anyone more than 1 centimeter, we definitely treat them. De-escalation, it's not the standard of care. 4 trials have not demonstrated non-inferiority, but definitely something to think about in patients who have very good risk factors. So if you have a patient who has, say, very strong hormone receptor, grade 2 tumor, and it's about 2 centimeters in size, node negative, maybe that patient does not need 1 year of trastuzumab. So select your patients right. And in countries such as ours, definitely we can be talking for those patients who have uh, financial issues, de-escalating based on their risk pattern. Pertuzumab, we should be thinking about in patients who are high risk, that is node positive and hormone receptor negative patients. And definitely TDM1 is here to stay for patients in the adjuvant setting. So to conclude, it's not easy to decide about adjuvant chemotherapy for a patient, both adjuvant and neoadjuvant. The questions we have to ask again are, what is the risk of recurrence for this particular patient? What is the risk reduction from chemotherapy? Both relative risk and absolute risk reduction. It is the absolute risk reduction that matters to the patient, not relative risk reduction. So I think that is fair. So if you're decreasing a risk from, if 2 patients recur and you give a drug and only 1 patient recurs, that is a 100% improvement, but the absolute improvement is only for 1 patient, right? So it's not just the relative risk, we also have to look at the absolute risk reduction. And again, we have to look at the patient's comorbidities, their tolerance to chemotherapy, take that into account, and then discuss this entire thing with the patient, and then decide regarding the role of adjuvant chemotherapy. To end with, how much is enough, and what do we think is the appropriate improvement that we need to have in a particular regimen to say that it is worth giving it. So is it worth giving it for a 2% improvement versus a 5% improvement? So who decides whether it's worth giving it or not? And I think we could have an entire discussion on how guidelines have arrived at these numbers. But for most guidelines, they suggest adjuvant chemotherapy if there is a greater than 10% risk of mortality from breast cancer at 10 years. So at the end of 10 years, if there is a 10% risk of mortality or more, definitely we are thinking about giving adjuvant chemotherapy. That treatment has to result in a decrease in the 10-year mortality by just 5%. Why did we arrive at the 5%? Because when they spoke to patients' relatives, doctors, it looked like most of them said that if I have even a 5% improvement in survival, I will take a particular treatment. So, adjuvant chemotherapy is generally not offered if the benefit is less than 3%. It may be given if the benefit is between 3 to 5%. So, these are all incremental gains. So, if you look at the absolute improvement in survival for a patient, anthracycline chemotherapy, 10% improvement, taxanes, another 5% improvement, dose dense, another 2 to 3% improvement, hormonal therapy, another 13% improvement, trastuzumab therapy, another 11% improvement. So absolute benefits you keep adding, and you hope that a patient who has a survival of maybe 50% just by surgery alone, in the best case scenario, when you're adding dose dense chemotherapy followed by trastuzumab, followed by maybe TDM1, followed by hormonal therapy, will reach that magic number of 90% and invasive disease free survival. So that is the goal that we have when we are giving adjuvant therapy. And for because the benefits of each therapy are small, so a taxane benefit is actually only 5%, right? In absolute benefit, if we see. So when it is such a small benefit that we are seeing with taxanes, do we really want to give it in a patient who already has a neuropathy? Whereas in another patient, it might not matter so much. So these are the things that we have to think about when we decide to initiate a treatment or continue a treatment based on side effects. So incremental gains are what we see with adjuvant chemotherapy in breast cancer. But what each block of treatment offers is a clarity that we should have so that we can help our patients in making those decisions. I will end at that. And yeah, open it to questions. Now, two things I have not discussed here. One is the NHS Predict. I don't know how many of you have used NHS Predict, but this is a tool that we use very often to see how patients are, what is the risk of recurrence for patients. And you'll be surprised with what we think and what actually is the risk of recurrence for these patients. So I'm just going to share the screen once. Let's see. Yeah. So this is the website. There are two sites. One is Adjuvant Online and the other one is the NHS Predict. Both are validated tools. And we have not spoken about Oncotype DX. I saved it for the hormonal talk and when it happens. But say you have a patient who's 65 years old, um, and postmenopausal, hormone receptor positive, HER2 negative, Ki67 positive, tumor sizes, we can say it's say 22 centimeters. And in between grade, she had an incidental lump. She has no nodes, right? So what is the benefit that we are actually seeing in this patient? So this is a 65-year-old patient with a hormone receptor positive tumor postmenopausal, and but her Ki67 is a little high. Grade is in between. Tumor is 2 centimeters. Let's make that 25, 2.5 centimeters. Do we give this node negative patient chemotherapy or not? Right? And let's see what the numbers are. When we give hormonal therapy, when we give chemotherapy, right? And here this is the improvement that we are seeing, the additional. So with surgery only, the overall survival for this patient is 75%. When we add hormonal therapy, it's 78%. When we add chemotherapy, it increases to 80%. So in our mind, we think these are terrific treatments that we are giving patients. But see, even with hormonal therapy, there is only a 3% improvement in the overall survival. What if you gave hormonal therapy for 10 years and you did a third generation regimen? So let's keep hormonal at 5 years and do a third generation. That is your dose dense chemotherapy. So that has gone from 78 to 81%, right? So when we give 80% with an AC followed by Taxol, this is ACQ 2 weeks followed by weekly Taxol, or ACQ 2 weeks followed by weekly Taxol. So it's just an 1% improvement in her survival. So is this a patient where we would do dose dense? No. So this is where, whenever you have free time, you change your numbers. We've now made the patient hormone receptor negative, and that is the improvement that we are seeing. So here now it's making more sense, where there is an 8% absolute improvement. If I gave this, it is 68%. So this is important for me when I am discussing with the patient. Uh, when I'm discussing with the patient different kinds of regimens. So if I have a 65-year-old who comes, do I want to give ACQ 2 weeks? 68%, 71%. So for a 3% improvement in survival, do I want to give a treatment that will have so much more toxicity? If it's a 40-year-old, maybe I would do it because one, the improvement will be much more. So let's say the same patient is 40 years old, right? We're now seeing more improvement, better tolerance also, the 40-year-old. So here there's a 3% absolute improvement. So that additional benefit I'm seeing in overall survival is much more. So for a 40-year-old, you also don't want to look just at a 5-year survival or a 10-year. You might want a 15-year survival, right? So we have to look at all these things and then discuss with the patient what is it they want from the treatment, how beneficial it is going to be for them, and help the patient decide. One patient might say, it doesn't matter to me, this 3% improvement from 77 to 80%. Even a 50-year-old might tell me, it doesn't matter. For 3%, I don't want to come every week for a weekly Taxol. I don't want to go through every 2 weeks of chemotherapy. I don't want to take that additional risk. Some patients might tell me, no, we want to take that treatment. So it differs from patient to patient, and we have to explain it to them in a way that they can understand. We need to have clarity on what is the benefit and then take it from there. So I think the NHS Predict tool is a real fun tool to play with. Even when you don't have a patient, you can always put in the numbers and see what happens, and take it from there. So any questions? Okay. Let's see, there are some questions in the chat.
Ma'am, can you please share the slides for us in our group so that we can read from it?
Sure. Yeah, I will check with
Yeah,
Navneet that can be done and do it.
yeah. Please, last class too, if it is possible.
Yeah, sure.
Thank
So
you,
one
ma'am.
question here is about neoadjuvant chemotherapy for 1A, 1B. So generally we don't do that because 1A, 1B tumors are as such not high risk tumors. So for triple negatives also, uh, or for HER2 positive, if it's more than 2 centimeters, we go for neoadjuvant chemotherapy. But otherwise, these are patients who are at a much lower risk. So, and we won't be tailoring treatment. So I think these patients we do upfront surgery. So in the Createx regimen, they left the neoadjuvant chemotherapy to the investigators. So some used AC followed by T, FEC followed by docetaxel. It didn't matter. It was the patients who did not have a pathological CR. Same question again about neoadjuvant in smaller tumors. So more than 2 centimeters is where most investigators and medical oncologists are now, even in the community, using neoadjuvant. No, NHS predict is the NHS population, not the Indian population. So since we don't have our data, I think it is a reasonable site to use both adjuvant and NHS predict. It's I don't think we have shown that our Indian patients are very different from the European patients or the American patients in terms of response to treatments. So or in terms of their response to hormonal therapy. So we might have a younger population of patients getting breast cancers. We might have more patients getting triple negative breast cancers, but that they will not respond to treatment like the other patients did, unlikely. So any other questions? If there are any other topics you guys are interested in, please let Navneet know and share it with me so that I know what to do next. Okay, I think we'll close. Thank you, everyone. Have a good night.
Thank you, ma'am. Thank you so much.
Bye.